Hi, everybody. We'll get started in just a couple more minutes. Okay. Hi, everybody. Happy Friday afternoon. Hopefully you can hear us and you can see the screen just fine, but if there's any issues, just put that in the chat. So my name is Joanna Cirillo. I'm the Clinical Practice Program Manager here at CHS under the Division of Nursing. And my co-presenter is Christy Fletcher. Hopefully you already know her. She's our 340B Compliance Officer. So a couple things before we get started. This meeting is being recorded. So this meeting, the recording, the slides, and some frequently asked questions will all be uploaded to the intranet by Monday. So I'll share those so everybody has access. Also, if you have any questions as we go, please put them in the chat. We probably won't be going back and forth with questions during this meeting, but what we will do is go through all of those questions and make sure they're included in the frequently asked questions that we will share on Monday. So again, I encourage your questions. I'm sure there's some things that we probably haven't thought through in this presentation, so please just share those in the chat with us. All right. So I'll just share an overview of what we're going to talk about today. We'll sort of have three different parts. So Christy is going to start us off with just a general review and overview of 340B and 340B eligibility, just to sort of set the stage. And then I'll talk about really the changes that are taking place, the reasons behind those. So 340B eligibility, there are two topics. One is TB. So if you work with TB clients, you'll want to tune in for that one. And then the second specific topic will be around STI and family planning eligibility. And then their third topic is around over-the-counter emergency contraception pills. So I'll hand it over to Christy. She'll go through some general 340B information, and then we'll move into the actual changes that are taking place.
Okay, thanks, Joanna. So as she mentioned, I'm going to provide a 340B drug pricing program overview. I'm going to start off with the facts. So this is a federal program that is administered and overseen by the Health Resources and Services Administration, along but the acronym is HRSA. And essentially, participating manufacturers agree to provide discounted pricing for covered outpatient drugs to certain healthcare organizations. So Virginia Department of Health is eligible as one of the healthcare organizations. And we are eligible because we are in receipt of 3 different federal grants. That's Title X, STI, and then TB. So those rules and regulations that the manufacturers must abide by, the same as for us as the eligible covered entity. We have rules and regulations that we have to abide by. And then, HRSA and the manufacturers can come in and sort of audit that and make sure that we are being accountable for those requirements. So the intent of the program is for us as safety net providers is to stretch scarce federal resources as far as possible, reaching eligible patients and providing more comprehensive services. So that being said, it allows us to provide affordable medications to our vulnerable population in the Commonwealth. Next slide. So when we talk about 340B priced medications, we talk about covered outpatient drugs, and this is specific 340B terminology in the sense that it outlines that prescription or over-the-counter medications are included. This includes biologics, but it does exclude vaccines. And that prescription or over-the-counter medication has to be prescribed by a clinician. So in addition to that, there are those agreements that have to be signed off and completed. So the manufacturer pricing agreement has to be completed. The drug itself has to be listed on the Medicaid drug rebate program list. And then the drug has to be listed in the OPACE database, the Office of Pharmacy Affairs and Information System. Next slide, please. So this is the standard example that's utilized across the board. We're looking at a physician administers 340B drug to an eligible outpatient client. Typically, the non-340B price for that drug is $100. The 340B price is $70, and so we have savings of $30. And we utilize those savings to provide other healthcare services that are within the scope of the grant, but it allows us to provide sliding scale fees or offer those to clients. And again, it allows us to offer access to drugs in an affordable manner. And then also, just to mention that the savings that we receive at the agency level are in the millions of dollars. Next slide. So talk about the 340B program compliance. I'm going to quickly run through these high level. We prevent diversion of 340B diversion, and that role and responsibility lies on the health department. Preventing 340B duplicate discount, that is the responsibility of the local health department. The billing and reimbursement team and OSS staff are responsible for ensuring that 340B modifiers are included on medications that are submitted to Medicaid. And the same there with Division of Pharmacy Services. If there are any prescriptions that were filled with 340B price medications, they're responsible and accountable for making sure that those modifiers are on the claims that go over to Medicaid. And as an organization, we are responsible to be prepared and ready for a HRSA or manufacturer audit. Again, the services really drive the 340B patient definition. And so we have to have auditable records if we were to be audited by HRSA or the manufacturers. So at the central pharmacy level or central office level, we work collaboratively with CHS and the grant program leads, and then 340B to develop policies and then update the procedure manual. Central office would be responsible for responding to manufacturer inquiries and HRSA inquiries and audits. At the central office level, responsible for providing ongoing staff education and then optimizing program savings. We talked a lot about compliance, and now we're going to talk a little bit about the consequences of non-compliance. So if we have a compliance concern that cannot be corrected, then we have to notify the manufacturer. Depending on the monetary value, it could be that we have to notify HRSA in a formal self-disclosure letter. And this could increase our risk for a formal audit from manufacturers or HRSA. It would also require us to make payment or repayment to the manufacturers. And the worst case scenario would be for the agency to be terminated from the 340B program. So like I mentioned before, a lot of the responsibility lies on the health department for creating those medical records and ensuring that we've got web vision registration, the clinical staff ensuring that the appropriate forms and the 340B documentation of services is included in the charts. Clinic staff have to ensure 340B patient definition is met before dispensing of the 340B drugs at the clinic level. Again, billing staff are responsible for ensuring those 340B modifiers are submitted on claims to Medicaid payers. The last one I haven't really spoken too much about is medication management or medication inventory management. So we are responsible for tracking the purchases at the central pharmacy, and then we track that distribution process to the local health departments, and then we ultimately record those dispensations in WebVision. So it's best practice to do an inventory reconciliation on a monthly basis. And that's really looking at WebVision to see what's in stock, and then looking at with the physical inventory, investigating discrepancies, and then also reconciling the inventory. Joanna's going to talk about current state, reasons for changes, and then future state moving forward.
Okay. So thank you, Christy. That was a lot of information that you likely already knew, but just wanted us to start with a baseline understanding of how important the 340B program is to our operations and why it's important. So part two, we're going to talk about on April 1st, what exactly is going to change or be clarified with the 340B program. So remember at the beginning, I said sort of three different parts. The first part is related to TB. So our TB medication is through 340B from the central pharmacy. So current state, what we're sort of dealing with right now, what we call start of care documentation is not clearly defined. So VDH as a whole doesn't have a clear point where we say, this is the document that starts the care of a VDH TB client, which is a 340B requirement. So that's current state. What we're going to change, and reason for change, is we want to strengthen that 340B compliance. And the TB 340B patient definition says you have to have like documentation in the chart before you dispense 340B medication. So all that to say, what is our future state? What are we changing? All VDH TB clients, LTBI and active TB, will need to have the TB newcomer health history completed in the chart before pharmacy services will dispense that medication. That will serve as our quote unquote start of care documentation. So this form, I will show it to you in a second, but it should look very familiar. I want to be clear, it does not need to be completed for like a contact assessment, but say a contact converts, becomes an LTBI client, before you give them any medication from VDH, you'll have to do this health history form. So this is what it looks like. It should be very familiar to you, TB or newcomer health program. And I would imagine this is not going to be a big change. Like I'd imagine that many programs, you're filling this form out on initial assessment, et cetera, and then you will go to order their medication. But this is now stated as a requirement for 340B. So in addition to doing that form, we put in a little bit of a check. So in the red cap, when you're requesting TB medications, you'll see one extra checkbox. It will be a required field, and it's basically just a self-check. So it'll say, I attest that the TB newcomer health history form has been completed and the client continues to receive TB services throughout the duration of care. And then that's it. And then you can continue on your way. This checkbox will be here every time you refill a medication, but you only need to complete that TB newcomer health history at the start of their care. So again, I don't imagine this is a big change. It's more of like a clarification of what exactly documentation do you need to be considered a VDH TB client. Again, I want to reiterate, if you have any questions, big or small, please put them in the chat. We'll be putting together frequently asked questions documents. So we will address and include your questions. We're just not going to talk through it right now. Okay, so that is it for TB. It's just that little piece. So we're going to move on now to sort of the second part, which relates more to family planning and STI. So Christy mentioned inventory. So current state inventory at each health department is really managed based on 340B or non-340B. But really the 340B program requires that inventory be separated also on the grant type. So STI or family planning. Our current system, this will come as no surprise, WebVision is not really advanced enough to manage inventory in the way that we need it to actually be compliant. So you see on the right-hand side, really we need 4 inventories at the local health department if we want to stay in compliance. 340B STI, 340B family planning, non-340B. So we would need it to be a really complex inventory system, and WebVision is just not capable of that. So that's our current state, is we're not exactly in compliance right now with inventory management. So the reasons for this change I'm going to talk you through in a minute. It's going to streamline operations both at the local health department level and the statewide level, the 340B program and the pharmacy level. It's going to greatly decrease the risk of 340B noncompliance. Put some little money signs in there, which Christy talked about. It really puts the agency at financial risk if we're at risk of being in noncompliance. And finally, a bit of a side benefit, we all know the increase in especially STI rates, syphilis, congenital syphilis in the last couple of years. And this change that we're going to make is going to increase our rates of STI screening and testing. So I see that as a benefit as well. Okay, so STI and family planning. Our current state clients could qualify under the STI or the Title 10 340B patient definition to receive 340B medications. What we're doing, future state, starting April 1st, to receive 340B medications, besides TB, because that's a little different, all clients will need to meet the STI 340B patient definition. That might sound a little radical, but I'm going to talk you through it and everything that you need to know. So this is the technical STI patient definition. What does that actually mean? Again, you will get these slides and you can click on the links. You need to have an established relationship with that person, provide healthcare services. The bulk of what I'm going to talk through is that bottom. So like exactly what do you need to do in each visit to meet this patient definition. So documentation, the sexual health history form must be completed and reviewed with each clinic visit. There are some exceptions, and again, I'm going to talk you through each one of these bullet points, and we're going to go through some scenarios. But depot appointments, like a depot only, nurse only visit, you don't need to do the sexual health history form. A follow-up treatment, you're not going to do that form again. The clinic visit record will indicate STI and HIV risk reduction counseling. And then on the encounter form, we have a new code, STI-ST, and education and counseling will be circled. So again, we're going to talk through each of these, but this slide serves a little bit as a summary of all the different documentation pieces that you need to meet the STI 340B patient definition. Okay, so 4 pieces. We're going to talk through each one. And again, we're still providing family planning services. We're just qualifying everyone under the STI patient definition. Okay, so the sexual health history form, I want to sort of acknowledge that if you are seeing folks just for family planning, you've never looked at this form before, they've never looked at it, it will feel like a big change, right? Like these questions might feel pretty invasive. I just want to acknowledge that from the get-go. But in Christy's 340B auditing, she's found over 90% of Title 10 clients are already dual eligible. So what does this mean? The vast majority of your clinics and the clients we're seeing as a state are blended clinics, family planning, STI. We're already using this form. We're already doing this. So really this change is for a small percentage, maybe around 10% of family planning clients that have never used or seen this form before. If you're familiar, this form used to be a lot longer. It's been shortened down to 1 page and divided into sections. So again, just to clarify, if you're seeing STI clients, you're already doing this. it's really no change for them. This form can be completed either by the clinician or the client themselves. And hopefully, you know, we're transitioning to an electronic health record. So before we know it, we'll have that, and it has a patient portal, so folks can actually complete all of these forms and questions through their patient portal before we even before they even get to the clinic. But this will need to be done. So say you have an annual visit, they're getting an IUD inserted, they'll now have to complete the sexual health history in addition to just the clinic visit record. So the clinic visit record, everyone getting 340B medications will need to have the STI HIV risk reduction counseling. If you're a Title 10 site, you'll still need to do the Title 10 counseling and check that box. But now, again, for people getting family planning services, they'll need to check both. On the depot flow sheet, so this is one of those exceptions that I mentioned earlier. So if someone is coming in for their second depot, it's a nurse-only visit, you don't need to do a sexual health history form, but you will need to do some sort of STI risk reduction counseling. So do you have any new partners since I saw you last? Are you using condoms? That kind of thing. Check the box. Again, if you're a Title 10 site, you'll check that box. And you'll circle education and counseling data code. And then this is the encounter form. So the STI-ST, so that is a new code. So anytime you fill out the sexual health history form, you'll circle that and you'll circle your education and counseling. For those couple exceptions, depot or a follow-up STI treatment, you'll just circle education and counseling. So you can think that anytime you fill out a sexual health history form, you'll also circle STI-ST, STI screening tool. For follow-up visits, like a follow-up STI treatment, you'll use this follow-up visit form and you'll check STI risk reduction. Counseling, you don't, again, need to do the entire sexual health history for just a follow-up visit. And you can just circle the education and counseling data code. Okay, so that was a lot of information. I'm going to run through a couple of scenarios to hopefully drill down what we're talking about. And again, I welcome all of your questions in the chat. So say you have an annual family planning visit and they want to get an IUD inserted. What are you going to have to do to meet the 340B patient definition? You're going to fill out the sexual health history form, which again, this is when I'm acknowledging this might be a big change for some people. So even though they're just getting an IUD, you will now have to meet that STI patient definition, which means giving them a sexual health history form. The client can fill this out by themselves, or you can sort of ask the questions in conversation as the clinician and fill it out with them. But again, IUD insertion, you'll fill out the sexual health history form. You'll complete still, of course, all of your other documentation, but in the clinic visit record, you will check off the STI risk reduction counseling, obviously based on their questions that they answered in the sexual health history form. And then you will check off STI-ST and education and counseling among anything else that is relevant to that encounter. Okay, so that's sort of a family planning visit. You'll add on that sexual health history form. Just another scenario. So say you did the IUD insertion, they come back 3 months later as like a problem visit, they're having breakthrough bleeding or they just don't like it, they want to get it removed. Here is maybe one of the trickier scenarios. To meet that STI 340B patient definition, you still have to meet the definition every time. And think about it, you don't exactly know what will happen in that visit. You could get 340B lidocaine, you could prescribe 340B oral contraceptives. So we need to meet that patient definition again. So you're going to give them another sexual health history form. It might seem a little counterintuitive, but you'll say, hey, I just need to, check if anything has changed since your last visit. So you'll give them the sexual health history form. We'll circle STI/ST, education and counseling, in addition to, of course, anything else that you're doing in that visit. Okay, another scenario, more STI related. So it's a contact to syphilis. You do your whole assessment and you are doing pick number 1. There's really not much change here for you. You're going to do the sexual health history form. You're going to STI HIV risk reduction counseling. And the main change is this is a new code, STI/ST. So you'll circle that. Pill refill visit. So we have that here on this slide. If it's just a pill pickup, encounter as VD and add the RX pickup at the bottom of the encounter details. And you're going to dispense that under the BD program code. Okay, we have 2 more scenarios. So say someone comes back 3 months later for their second depot. It's a nurse-only visit. This is one of the exceptions, so you don't have to complete this entire sexual health history. But on the depot flow sheet now, you will notice that there is an STI/HIV risk reduction checkbox. And you will just circle education and counseling. So again, they've come in for their depot. Okay, any new partners, conversation like that, and move on. Another scenario, so someone comes in for treatment of a positive chlamydia. You will use the follow-up visit form. You'll check off STI/HIV risk reduction counseling and do all that counseling. And you don't need the sexual health history form. So those are really our 2 exceptions, like a depot only visit, which is our 5th example, and the follow-up visit for STI treatment, where you don't need to complete the sexual health history form. Really all other, if they're getting 340B family planning or STI medications, they will need that sexual health history form done. I know that was a lot of talking, but again, we're going to send the slides, we'll send this recording and more frequently asked questions on Monday. So you will have additional resources. Okay, do you guys want to add anything?
There's one question in the chat. I know we said we weren't going to do this, but on the sexual health history form, are all 3 sections required? Yeah.
I would say really the goal to meet the definition is that you're doing that education and counseling and getting them the right treatment and tests that they need based on their sexual history. So part 1 and part 2 I see as really essential. Part 3, you can see it says, if something makes you uncomfortable, you don't have to answer that. I think that's getting a little more specific so we can tailor the right tests or services to the right people. But if at least part 1 and part 2 are completed, I, as the nurse, would know, okay, I think we should recommend these certain tests, that kind of thing. So I think we can get to the goal, which is the right recommendations based on just part 1 and part 2. Anything else? Okay, so that was family planning and STI. We have one more 340B topic for you guys. So this is around emergency contraception. So what Christy mentioned in the very beginning, 340B medications actually require a clinician prescription. So what does that mean for emergency contraception? We have a standing order for emergency contraception or Plan B, so that if a new patient comes in the door and they really need it, I, as the nurse, can use the standing order to dispense 340B. That's actually not in compliance. Well, if we wanted to be in compliance, what we would have to do is make everyone see a clinician and they would get a prescription. So current state, we're using the standing order for new patients, which is really actually not in compliance, and it's opening us up to risk. However, we really want to make sure this medication is as accessible as possible. It's as easy to get it as possible and expanding access. So what are we doing to expand access to emergency contraception and also eliminate risk to the 340B program. Division of Pharmacy and CHS are going to purchase all non-340B generic Plan B. You at the local level will really not see much of a change, except that the package might look a little bit differently in the future when you get it from the pharmacy. I just want to be clear that's over the counter. Ella can still be prescribed if the clinician prefers, but of course, like right now, that would require a clinician visit. So this can be delivered by the nurse using a clinical protocol. So another change, since it's over the counter, we don't really need a standing order anymore because it's not a prescription medication. So CHS is going to be revising that into a clinical protocol. So including a little more information about the documentation and everything else. So you will see that the standing order that we have right now becomes a clinical protocol, and what you're actually dispensing is non-340B, because for 340B, they'd actually need to see a clinician, and it can be simpler now that the medication is over the counter. You will document and record in WebVision and on the visit record just as you do now. So really, for this, you won't see much of a change. So here's the clinic visit record where you would check that and administer or dispensed depending on what happened in the clinic, write your initials and all of that information. So really there's no change except the box might look a little bit different. Okay, so April 1st is sort of our go live date for all of these adjustments. I know you all have been doing a lot with your inventory because basically the goal is to use down all of the family planning Title 10 so that in the future, starting April 1st, it can all be the STI grant that we're using. CHS is going to review the standing order, basically make it a clinical protocol type document. And we're here for your questions. So resources, this slide deck, this recording, the frequently asked questions that will include your questions from today will be on the intranet by next week. We email that to all nurses and include it in the nursing newsletter. And we still have a little bit of time, basically 2 weeks. If we've majorly missed anything or you're still super confused, I would welcome your questions. You can reach out to myself or Christy Fletcher, and we will get back to you and answer any questions that you have before April 1st. Anything else, Christy?
Thanks, Stephanie. We'll be presenting next week at the clinicians meeting too, like an overview of what we talked about, answering lingering questions. So that's another resource that's coming up. I think you guys are doing the nursing.
Yeah, at the end of this month, we have the nurse managers meeting too. So we'll go over all this again with nurse managers, just to make sure everybody's clear and we didn't miss anything major. I'm sure there are situations that we haven't thought about or accounted for. So yeah, again, if we're missing anything major, just let us know. Or something is a little confusing, we'd be happy to help. Okay, I want to thank everybody for your time. That's it. And again, we will be emailing all of this to you. Happy Friday.